It's a real pleasure to see everybody today after a long time. I'm going to say something about comparative assessment of aortic regurgitation post TAVI in a commercially available transcatheter heart valve. You all know that aortic regurgitation after TAVI negatively impact patient prognosis. A meta-analysis comprising over 15,000 patients show a 2.12-fold increase in mortality for patients with more than mild regurgitation after TAVI. And we are also exploring the impact of mild regurgitation. Now, clearly, with the rise of the minimalist TAVI era and without general anesthesia, echocardiogram evaluation during the procedure become restricted, and aortogram reemerges as a practical and familiar tool for the interventional cardiologist. We just presented the ACC, or a series of 2,400 patients, and it was published in the JACC intervention, and there was a very provocative editorial of Bernard Cousins. Can you please ask the echocardiographer to get out of the catheterization laboratory, which is quite provocative. Just a word about the quantitative assessment of regurgitation. You perform using a single aortogram with video densitometry technique. Basically, you have a reference area and a region of interest. You look at this time density curve of the reference area and the region of interest, and the ratio between the two areas under the time density curve is translated in percentage of regurgitation. This is an action. You could see the color-coded regurgitation, the assessment of the color-coded video densitometry. Clearly, it is at the upper part of the valve in this case. We spent some time between 2016 and now to validate that in vitro, in mock circulation, in animal models, pigs and sheep. We correlate that with transthoracic and transesophageal echo, and with Wahab, we look at MRI. You see here an MRI with the classical regurgitation fraction of 33%, found in this case 32% by video densitometry. This is a pretty good relationship if you think that the aortogram was done after the procedure and the MRI in the place of Wahab within 30 days. So we were quite pleased by this relationship. What is important is this value of 17%. I don't have the time to show you, but basically looking at the transthoracic and transesophageal echo, 17% was the best cutoff criteria to diagnose on echo a moderate to severe. So that number came back repeatedly as the difference between mild and moderate of severe on echo. And we were pleased to see that this number has an impact on prognosis. This is a Brazilian series with a follow-up of 4 years. And you see when you have regurgitation of less than 17%, your survival was at that time 68.3%. When it was above 17%, it was 39.5%. To date, little is known, as a matter of fact, about comparative, quantitative, and geographic assessment of aortic regurgitation clinical trials comparing transcatheter heart valve. So we thought to evaluate aortogram from clinical practice in a large multi-center cohort of TAVI patients in order to determine the features among the ceiling features among multiple commercially available platform. It is a retrospective analysis, we have to say that, but from multi-center and multi-continental cohort. The only thing we were asking to our colleagues, because they are all friends, is to provide us with consecutive patients that underwent TAVI following each participation institution heart team recommendation. And the aortogram were analyzed using the video densitometric technique. Offline, it's a P-medical system, but it's now online with Philips. And what is important is that we work as a totally independent core lab. It is not sponsored, it's a purely academic activity. You see, we had friends in Canada, Brazil, Netherlands, France, Sweden, Germany, Italy, and Japan. So altogether, we had 4,329 TAVI cases in 115 patients. There were no final aortogram performed. Among these 4,214 aortogram without acquisition protocol, prospective acquisition protocol, a sizable number were non-analyzable because there were an overlap of the descending aorta with the region of interest, the outflow tract, deep breathing, overlapping of the descending aorta with the reference area, some table motion, some insufficient time of image acquisition, some radiopaque structures in the region of interest, and some really insufficient contrast in the aortic root. But we end up with 2,400 aortogram analyzed. Today, in prospective series or in our first randomized trial, the acquisition is available between 95 and 98%. So this is what we have evaluated, a lot of Lotus, core valve, SAPIEN 3, Evolute R, SAPIEN XT, Accurate, Evolute Pro. We eliminate these few cases. We were below 50 cases. Direct Flow Medical, Centera, Innovar, and Lotus Edge, although we have now a large series of Lotus Edge, but not yet analyzed. And we see in Europe more and more valve coming from the Far East. Here you have the My valve that we have had to the series published in JACC Cardiovascular Intervention last month, and also the Venus, but we have also the Taurus now, the VitaFlow Microport, and the Hydra of SMT. There is in Europe a lot of valve coming from the Far East, and some of them are very good. Here you see the My valve, which is coming from India, nickel chrome, bovine pericardium, balloon expandable. They just have now the 32 millimeter valve. It's still compatible with a sheet inner diameter of 14 French. It has an anti-leak skirt and an external pericardial wrap, and it is CE mark since April 2019. And then you have the Venus, which is in nitinol, self-expanding, porcine pericardium supraannular, also a 32, but the sheet is about 90 French, and it's an anti-leak skirt. This is basically the result. What you see here is the cumulative curve of the percentage of regurgitation going here at the bottom from 0 to 60%. This gray zone of this line is really for us the cutoff criteria between mild and moderate and severe regurgitation. It is 17%. As you could see with the Lotus, we have really only a few cases with more than 70%. The second one in purple here is the My valve, 108 cases. Then there is a large cohort of Evolute R, Pro, SAPIEN 3, Accurate, and and Sapien XT, about 1,000 patients in this blue curve. He is a newcomer. It is the venous valve of De Nova. And then you have an historical valve, the core valve, which in more than about 30% of the case has moderate or severe regurgitation in the first generation. Usually we quantify the aortogram by non-trace less than 6%, 6 to 17 mild, and above 17 moderate and severe. You see here again the distribution between severe in red, mild 6 to 17 in blue, and in green none or trace. So obviously the best one is the mechanical expandable of the best one is the Lotus. Then you have the MyValve, who make a very good entry in Europe with 2.9 of moderate to severe. We have Evolute Pro with 5.3, Sapien 3 8.3, Evolute R 8.8, Sapien XT 10.9, Accurate 11.3, Venus, the Chinese 18.3, and historically the core valve. If you look only to the balloon expandable valve, we are pleased to see that the MyValve made a very good entry in the European market with 6.3%, as good as the Sapien 3, 7.6%, and the Sapien XT. This was significantly different from the MyValve, was the Sapien 3 was not significantly different with a post-hoc Bonferroni test. In the self-expanding, only the core valve is different from the other. The 3 star indicate that the Evolute R, Accurate, and Venus are not basically different from the Evolute Pro. So the strength of this type of approach is that it's real-world data in consecutive patients with daily clinical practice. It's a quantitative assessment with a validate and reproducible method. There is now a few centers who has the technology either online or offline. The inter-observer correlation of that software is spectacular, with a coefficient of correlation of 95%. And in the blunt Alman, the difference between two measurements is 1%, with boundaries of agreement of 4%, and the same for intra-observer. And one important point is that it was analyzed by an independent core lab with no sponsoring of the industry. And you know, with a long history of trialists, I can tell you a story about the core lab, which are quite interesting. The limitation is that no randomization was performed for the valve comparison, what may inherently lead to selection bias, although it's now introduced in the randomized trial as a technique in parallel with the echo, so you get both information. It was retrospective without an acquisition protocol, so the feasibility of the analysis is moderate, with 41% of arthrogram not analyzable for the reason that I have give you. But I can also tell you that we have published a quite large registry, Assess Regurg, where there is a prospective protocol, and then globally the analysis was feasible in 95.5%. And our Japanese friend had a 100% feasibility of analysis, respecting very much the separation between the descending aorta and the region of interest. Since they were not the purpose of the present report, no information regarding calcification, presence of bicuspid valve, aortic annulus size, shape, diameter, etc. That was not the purpose, but we are now ripe, I would say, to do this kind of analysis. And the final conclusion is that so far the Lotus valve had the lowest amount of acute regurgitation post TAVI, and the first generation core valve has the highest. My valve and Venus, two newcomers, demonstrate acceptable amount of aortic regurgitation. This objective assessment may be of great value for clinical trial, comparing different valve, technique of implantation, and clinical scenario. And in technique of implantation, we have published the regurgitation by video densitometry before and after post dilatation. It was quite impressive. But of course, we have to get involved, and we are involved in these head-to-head comparison randomized study. So we will have to keep working in the field. Here they have a long list of good friends who help us to collect these consecutive series that I have presented and has been published in JACC Intervention last month. Thank you very much.